Blasis.
Thank you. Thank you, Mr. Chairman. I hope you can see me and hear me clearly. Can you see my slides?
Yes.
Thank you.
Yes.
So it's a great honor on behalf of our team, and you can see our team there. Actually, the team is bigger, but I just pointed out the leadership, like the people that are key in making decisions about our patients. And I'm going to present 3 quick cases to highlight how important it is for the heart team to convene and discuss all the important aspects of complex patients. And I took the liberty, and I hope Kostas Pargias is okay with that, to change the title a little bit. And the cases I'm going to show will highlight when interventional cardiology comes to the rescue of cardiac surgery. And it is a bit provocative, and I hope that Dr. Patakos will not be angry at me. He knows how much I like him and I respect him, but we do see that from time to time that difficult situations in cardiac surgery can now be bailed out by percutaneous techniques. So let's have a look at this. So this is a first case. This is a young patient that we treated recently. He has diabetes, hyperlipidemia, and he had a recent NSTEMI, 47 years old. He ended up in our hospital with severe LV dysfunction, severe functional mitral regurgitation. You can see he had suffered clearly an inferior, maybe posterior myocardial infarction, but also the anterior wall was hypokinetic, ejection fraction was 30%. And the plan was to do a bypass surgery on this patient with diffuse disease and potentially MV repair. But what happened is upon anesthesia induction, he went into cardiac arrest. So the surgical team had to act on that, put him on ECMO. And without giving any cardioplegia, they were able to do a triple bypass on him with success. But they didn't open the heart, they didn't repair on the mitral valve, which is probably the right thing to do. And we ended up on the patient in ITU, unable to be extubated on non-invasive ventilation, requiring significant dose of inotropes as well as IV diuretics on constant pulmonary edema. So we decided to go for a rescue mitral clip procedure in order to stabilize the patient. And this is how the heart looked like. You can see that there's a lot of MR. You can see the ventricular pulling of both leaflets, severe MR, central jet, A2P2 area, all because of ventricular tenting posterior. You can see that all. And of course, lack of coaptation. Unfortunately, I didn't have the images during surgery, but it was really a nightmare. So we decided to go for the mitral clip, and we ended up, this is an XTW, you can see it's open. We are checking the grippers, and the anterior gripper is the one with the marker here. And we check the perpendicularity, and then we dive into the ventricle. And it's actually quite easy to grasp the leaflets, even with coaptation gap. Having these big devices in the old days when we had the NT clip, the small clip, it was very, very difficult. But actually grasping is very straightforward, and we're able to close very carefully under echo guidance, securing the leaflets in there. You can see the smoke on the left atrium, spontaneous echo contrast, the immediate reduction, almost elimination of mitral regurgitation, which actually had an immediate hemodynamic effect on the patient. So the inotropic dose was reduced, the pressure dose was reduced, and patient had a very quick recovery. I'm just showing some pictures, and then the left to right shunt from the transseptal puncture. These are the hemodynamic effects on the left atrial pressure. You can see the V wave was about 45 and went immediately down to 30. But the most important thing is that the pressure waveform in the left atrium was truncated from a rather ventricularized waveform. It went to a more atrial waveform with an AAV. This is the patient at 1 month. Prior to discharge, the patient also received a defibrillator and ICD. You can see the LV is still to recover, but the patient's actually done exceptionally well. Within the first 2 days, he was able to be weaned off all the support and go to the ward and be mobilized. I will remind you all that this was a 47-year-old patient who's actually now able to we're able to escalate all the heart failure therapy for him, and hoping that with the perfusion and the heart failure therapy, his ventricle will have some recovery in the future. I don't know if you want to discuss the case.
Vlasis, can I ask something in this case?
Of course.
Because the topic of the issue is the role of heart team, is the decision of the heart team correct in these patients to go for surgery?
Well, the patient required revascularization, and it was a diffuse. Unfortunately, I didn't have access to the coronary angiography, but it was a diffuse three-vessel disease on a diabetic patient that recently had an end-STEMI. So I would agree. I mean, for me, putting 4 or 5 or 6 stents on a young patient on a diabetic young patient is not a great idea. So I'm very happy with bypass surgery as a revascularization modality. Now, the big question here is whether you go for, in my opinion, of course, and that's open to your criticism, if you go for bypass as well as mitral repair or not. Here, the surgeon, who's, Adonis Pitsis is a very experienced surgeon, didn't have the opportunity to go for mitral repair. It was part of the initial plan, I think, because the patient crashed on the table prior to putting him on a bypass machine. He did the on-pump without cardioplegia, and probably that was the reason why the patient came out alive from this operation. But the revascularization was adequate, and then the MitraClip, there's a lot of evidence about the MitraClip in acute MR. We have participated in a couple of studies. There's a big registry, a REMI registry, that shows that it's a very safe procedure and is actually a very effective procedure. So the question to you is it right to do bypass and MV repair during an operation as the guidelines suggest? Or shall we do the revascularization and do a MitraClip or a TEER procedure in the second stage? I mean, that's a question that is always in my mind.
Yes, thank you. Dr. Patakos.
No, okay. Good evening, Vlasi. This is Stratis Patakos. You actually didn't make me feel worse, actually better. It's nice that you... No, I'm durable in those, so during the years I've become very durable. Question, given my brotherly relation with Adonis Pitsis, I can ask him, I wish he was online so I could directly, given the fact that the ejection fraction was 30 and now is 15, I'm sure that the patient crashed. I'm sure that what he did was the right decision for the moment. But just for the sake of our conversation, since the patient crashed, the situation was very difficult. You can see him now with ejection fraction 15, so he is not the best possible situation. I'm wondering if the deterioration happened the next few days, 1, 2. How many days later you did the mitral clip?
48 hours after the
48 hours. These 48 hours were very detrimental for the myocardium. What would be the, and of course we don't know because experience is with time. What about if at that time, since he was on bypass, he had put a mechanical valve with and then a balloon probably, and then probably with bad results. But the ejection, given the fact that the ejection fraction was 30, he did the bypass surgery. What about if he had proceeded and replacing the valve? Something tells me that he might have a little bit better result. What's your opinion?
I don't know. I'm quite nervous in the prospect of replacing a valve in such a bad ventricle. And of course, you know better than me, but what would be the price that we would have to pay if we had put the patient on bypass and we had administered cardioplegia during the index operation? So I think Andonis, Andonis referred the patient to us to do it. So I'm not talking behind his back, but clearly if he was here, he would be able to explain his thinking process. But clearly he didn't want to administer cardioplegia. He didn't want to open the left atrium and replace the valve, the mitral valve. And I don't know, I have a feeling that the MitraClip in these acute situations where the ventricle is really, really poor, but non-dilated, this is the most important thing, it's probably a good thing because it has a remodeling effect on the subvalvular mechanism as well as the annulus. and is a durable and very low intensity intervention. There is also a pop-off effect. You can see it doesn't eliminate the mitral regurgitation. There's a little bit of residual MR, but probably is good for this ventricle. Now, what is interesting is that the ejection fraction looks horrible. The patient looks great. And we do see that when we do mitral clip procedures in this sort of cases, because the cardiac output actually increases. And for me, there is a prospect because I believe that he had the best revascularization possible, having a grafting instead of stenting. I think probably this patient will do well, but it's early days to say. Maybe I will be able in the future to show his late outcomes.
Now move to the second case.
Just one more
second
comment.
case.
Just one more comment. Costas. Hi, Vlasic.
Costas, yes.
Hello.
Hello. Hi. Great case and great save. I think the whole process of doing things here was very logical and very radical decisions. Just in the last slide, I think I saw some considerable aortic regurgitation. Was it my idea or not?
Mild.
Oh, no, mild. Okay, sorry.
Yeah.
Okay, I was tricked. Okay, let's go to the
Let's
second
go to the
case.
second.
Dr.
All right,
Patakos is
so-
next to me waiting for the next case.
Okay. See, I made a special introduction for Dr. Patakos because I have so much respect for him, so I'm really nervous. But anyway, I'll move on. So case 2 is a 75-year-old female patient. She had mitral repair from mitral regurgitation. In fact, this didn't happen in our center, so in all disclosure, I'm going to say that. It wasn't clarified why she had mitral repair, what was the mechanism of the initial mitral regurgitation. There is this phrase that for possible mitral prolapse, which really, I don't know, it was 3 years before. The patient had paroxysmal AF, sick sinus syndrome, and then about a year before she received a pacemaker DDD because she had a sinus rhythm as a baseline rhythm with bouts of AF. No coronary disease, and now she presents with severe MR and TR and recurrent admissions for heart failure decompensation. So this is the mitral. Now, you will be able to see on the left picture that there is a semi-ring. So you don't see a ring in the anterior aspect of the valve. There's a lot of MR. There's stenting of the posterior leaflet. But you might be able to see that there is some color going between the ring and the native annulus. And hopefully this is better highlighted in this clip here. But you can see on the right picture, there's a gap between the in systole between a part of the ring and the native annulus. So there is a partial dehiscence of the ring that doesn't support the posterior leaflet, which is tented. Actually, is moving still, but it's quite deeply tented into the LV. The LV is actually quite nicely preserved. You can see the dehiscence probably at about 7 o'clock here. But it's not a rocking ring and it's not a paravalvular leak. So it's a para-ring leak as well as a transvalvular ring. So the leaflet is the main mechanism here. It's all tenting. On top of that, there's a lot of tricuspid regurgitation. Actually, tricuspid regurgitation looks horrible and it's coming from the posterior aspect of the valve. We really tried a lot to interrogate the leaflets with relation to the wire. The wire was in the posteroseptal commissure and it wasn't really impinging on the leaflets. It was more a functional mechanism. So the plan here, after a lot of discussion, was to actually go and repair the mitral, which was the key aspect, but also look into the prospect of repairing the tricuspid and do that in the same setting. And we did publish our experience recently, about a month ago, of 42 consecutive cases performing with a single tri-clip guide both valves. It's actually safe, very effective. And it doesn't take a lot of time because the tri-clip guide is ideally suited for the tricuspid valve, but also for the mitral valve because it allows you to gain height and it has double steering, so it is even better for the trajectory. And this paper is here just to show the feasibility of that, and I know Abbott is planning on getting an omni guide, like a single guide for both valves. So this is the procedure. Because the posterior leaflet was very short, it was 11 millimeters only, 10 millimeters, sorry. We decided to go with a small clip NTW in the middle of the valve. And actually, it was very easy to grasp because, having the ability to grasp independently the leaflets helps a lot. And you can see that we really got the leaflets in the middle where it was supposed to be the problem. And what was striking is that the mitral regurgitation disappeared almost. And we were a little bit concerned if these ring dehiscence will actually cause some additional regurgitation, but all it was doing was not supporting the posterior leaflet. So by putting the clip in the right spot, we actually did the job. And here is the final result. There is mild residual mitral regurgitation. What is very interesting is look at the LA pressure before and after. So it was 60, 61, the V wave with a mean of 29. It was completely truncated, so V wave of 17 with a mean of 8. So that is really very promising for the patient. So we then withdrew the guide back into the right atrium. And when we do that, we always observe the behavior of the septum. So you can see there's a bidirectional shunt because the tricuspid regurgitation jet is actually directed to the septum. You can see this broad jet coming from below. But the patient was stable. It didn't desaturate. She didn't desaturate. So we then went with the next DW clip to the sweet spot. You can see that there is some prolapse of the posterior leaflet, very close to the wire, but we are just central, just anterior of the pacing wire. On the right picture, you can see the wire is in the commissure. We are able to grasp quite nicely there. You can see both leaflets coming in. And we had a marvelous result, really unexpected. I was thinking of just reducing the regurgitation. And it was quite interesting that we had a left to right shunt. So this bidirectional shunt completely eliminated after we decompressed the right atrium by putting this clip in. And these are the pressures of the right atrium before and after. It wasn't a very huge pressure, but still enough to create this bidirectional shunt on the septum. So again, patient did very well and got discharged. I don't know if you have any questions or any comments about this case.
Any comments? What is the cause of the tricuspid regurgitation? Is from the wire of the?
That's an excellent question. We think it's functional predominantly in that the wire wasn't actually, it hadn't destroyed the leaflet or wasn't impinging on any of the leaflets. But it was very close to the wire. So normally you would see the wire being in the posteroseptal area and typically an anteroseptal jet coming as the cases we showed this morning, but this was very close to the wire. So I have a feeling that it was somehow interfering and the plan was to go close to the wire and grasp the anatomy in this area and hopefully this will do the job, and as it did. We've been a bit lucky in this case. Normally we wouldn't have such a great result very close to a wire. But it's always very difficult to tell.
Okay. Any question? No. We can proceed to the third case.
So the last case is a TAVI case, and I hope it's interesting. So this is a 72-year-old female. This lady had 4 years before, at the age of 68, aortic valve replacement, and she received a Percival size M, according to the documentation. But she went okay in the first couple of years, maybe 3 years, but in the last year she's going deeply into heart failure with a couple of rehospitalizations, but she's really very sick. Diabetes, hypertension, chronic renal failure, and on the echo there was some moderate plus perhaps aortic stenosis, maybe low flow, but there was also some aortic regurgitation, so signs of early degeneration of this Percival valve, which was really bizarre. And we tried to find out why, and when we did the CT scan, we found this. So there is this heart-shaped malformation of the frame of the Percival valve. We thought that this was due to underexpansion. Why it was underexpanded, it's very difficult to tell because there's no calcium adjacent in this area. So perhaps fibrosis, but still, it's very difficult to explain this. But clearly this creates a diameter in this area which is almost 12 millimeters. And that was the reason for early degeneration, I think, because of malcoaptation and pinwheeling effect, etc., etc. Now, Percival, you've all seen this valve and you've treated it. It's a supraannular valve. The posts are these wiggly metal frames and the leaflets are quite high. So we had a concern of the relationship of the leaflets to the coronary ostia. The coronary ostia wasn't too bad. I mean, the left was at 14 millimeters, the right it was, I think, 11. But having the leaflets in a supraannular position was a little bit tough. So we thought we had two challenges here. Of course, we had the discussion within the heart team, and because the patient was very sick and it was a second redo operation, it was decided to proceed with TAVI. But we had two challenges. The first is to open up the frame of the perceval valve in such a way that we will not risk of rupturing the annulus, for example. And the second challenge was to put a valve in such a way that we preserve the coronary ostia. And we decided to go ahead and do that with double coronary protection, active protection. So we put a guide catheter using both radials. We put a guide catheter with an extension and a stent in the left coronary. You can see this guidezilla and the stent in there. And we also use the coronary wire and the stent on the right side as well. And you can see that there is a lot of aortic regurgitation even by just taking the shot on the coronary here. And then we just tried to find a view from the CT scan that we could see this indentation. On the left, you can see the indentation of the perimeter, like the base of the perceval valve, this dent at about 3 o'clock. But we wanted to see that profile somehow. We crossed the valve very carefully to make sure that we didn't go underneath the posts. And we used an Atlas 20 millimeters wire. You can see perhaps this indentation, this double shadowing here on the frame, how the Atlas wire is pushing it out. We didn't have to go too high on the pressure. And then we used an accurate Neo2. Why we used an accurate Neo2? First, we have a big series now using a surgical valve-in-valve with accurate Neo2. We've presented it and it's about to be published. We believe that it's a very good platform for valve-in-valve because it's supraannular, so it gives you a bigger area. You can do commissural alignment quite easily, and you do have access to maintain your access to the coronaries. The other thing with this is we had very clear markers of where to go. So the plan was to get the marker of the accurate, actually it's an accurate prime, not a Neo2, the accurate prime to go to the top part of the bottom stent frame of the perceval valve there. And you can see how we went and we achieved commissural alignment with 1-1-1 and 2-1 configuration on the 3-cusp and cusp overlap view. And then we just moved down to the desired post position. There, we opened up the upper crowns, the arches, and then the frame. We did that under rapid pacing to make sure we don't have any migration. It stayed in the desired location. It opened quite nicely. And then we just checked on the coronaries. The left was open as well as the right. And on the aortography, we didn't have any PVL. And we didn't have any gradient. So this is the gradient before. Surprisingly, the gradient wasn't huge. It was almost 20 before, and it was about 10 or 11 after. But the patient actually is doing very well. The patient picked up on her activities without any problems, and she's doing better. So I will speak my conclusion. So the heart team approach is mandatory for treating structural and valvular heart disease. Of course, heart surgery has been the bailout method for interventional procedures, and it still is for sure. But the advancement in percutaneous procedures now have increased the potential for bailout in surgical complications or surgical unmet needs. I wouldn't say complications, I would say that surgical procedures that now have to be treated without surgery. And of course, a well-rounded multidisciplinary discussion prior to any management of this patient is mandatory. So thank you very, very much for your attention, and I'm very happy to discuss and answer to any questions.
Thank you very much, Dr. Ninios. Excellent work. Congratulations. We don't have time. Thank you very much.
Thank you.